womb suffering to me
Mm-hmm.
is the inappropriate inheritance
Mm-hmm.
that Black women have received over generations of time that teaches us to normalize severe gynecologic disease. And we learn how to do that because we're taught to normalize and neglect how we feel in service instead of being strong
Yeah.
and caring for others.
Welcome to Pop Syllabus. I'm your host, Christiana Mbakwe Medina. Today's guest is Dr. Kemi Doll, author of the new book, A Terrible Strength, The Hidden Crisis of the Black Womb and Your Survival Guide to Healing. When it comes to Black women, we talk about maternal health a lot, and we talk about the risks of breast cancer. But there is so much life in between and beyond that. Today, Dr. Kemi Doll helps us understand it all. Dr. Kemi Doll, welcome to Pop Syllabus.
Thank you.
I am so happy to have you here today. You're a gynecologic oncologist, OBGYN, and a professor at the University of Washington. And I want to talk to you because I love your work around women's bodies, specifically Black women. And this is a pop culture podcast, but it's so interesting that this is something that's in pop culture and in the zeitgeist right now. Whether it's Serena Williams talking about the challenging birth she had, or Beyonce, it's Lupita talking about fibroids, it's Lena Dunham talking about living with endometriosis. It feels like there is this moment where women in pop culture are saying, I am going through stuff with my body. I want to know what led you to this work and this specialty. Because the timing of it seems like the book and what you do seems so perfect for this particular moment.
Which is wild because I never could have conceived of that harmony all happening at the same time. What led me to the specialty is I love taking care of women, for one thing. Also men and, their behavior, their feet. I was like not into it.
Yeah.
So that's why I went into OBGYN to begin with. And then I went into GYN oncology or gynecologic oncology because there's just something about taking care of people when they're facing mortality, like when they get the worst news.
Yeah.
Now you have cancer. There's just another level of intimacy and immediacy that I was drawn to. It's like everything matters.
And you weren't scared of like the heaviness of that job? Because I think I don't know how I would cope with just the bad news of it all. Even though I know you deliver a lot of good news because doctors are healers.
Because the thing,
doctors are healers.
You have just enough patients. I had just enough women that I had the honor to take care of that made it so that the balance was okay. But also, I will tell you, because I went through OBGYN training first, I don't think there is anything that competes with the level of sadness of obstetric trauma and obstetric grief,
for sure.
So like I remember that at some point I was doing the horrible job of when a woman comes in to have her baby and you have to tell her baby has died. You can't find the heartbeat. And I just remember, I don't know how many number of times it was. And I was like, it just was aching. It was so hard. So it's almost like you choose the hard. And for me, I was like, I'm going to deal with the full adult. Who it's bad news, but we're going to get through this together.
I love your book because it's like part memoir.
Yes.
And it's part medical manual.
Yes.
And the memoir part, I would just say as a fellow Nigerian, I think you were very courageous in talking about your family stuff. I do not want to spoil it because I want you all to read the book. But Dr. Kemi, you unveil yourself, right? You don't go down the trope of like good Nigerian immigrant.
I really don't.
But the pain that you suffered in your family system is what kind of led you to medicine and the challenges you had in college. And then you had a very unconventional road to medical school. Like how has that informed your practice, like in current day? But, when I was reading it, I was thinking, this is another reason why there are so few Black doctors. You were exceptional from the beginning when you were having challenges in college and you failed at and then you came back. But for a lot of people, especially minority doctors, that is then the end of the road. And we don't get somebody like you who can see their patients in a different way.
Oh, it's so true. And it's a good question. I've asked myself too, like, why was I able to keep going? I do think that there is a certain resilience and strength that is born of trauma, unfortunately.
Yeah.
And I learned very early on in my family system from a very young age to rely on myself. And there's a way in which, even though everything was kind of broken for me along the way and some of my journey, I was hardwired to essentially not stop trying until I literally physically could do nothing else. Um, and this sounds really sad, but in a way, if you don't really feel like you've had that community of love and support around you, as things are going well, you didn't have that anyway. When the challenges come, it's the same. It
Yeah.
wasn't like I could deal with it, I guess.
Yeah.
It has shaped so much of my life because people ask me a lot, like, what is that motivate? Like your engine, what is that
Yeah.
engine? And I talk about this a little bit in the book. Like, I remember feeling that like spark come on, which is that like, I will not stop until I am stopped.
Yeah.
And it's now modulated so I can be healthy.
Which we'll come to at the end. Don't spoil it.
It
Don't
has-
spoil your own
yeah.
book. Because
I'm
you
not
do
gonna spoil my
at the
own
end, at the end you do kind of talk about how to heal, which I do want the audience to get into.
But like I think we need to be honest about that stuff too.
Yeah, of course,
because
yeah.
it's like, especially as Nigerians, I think, we achievers, we are the success, etc. And it's like, yes, but I think, I'm curious about your perspective. I'm sure there are places that originates from that are very healthy, but there are a lot of places where that achievement machine comes from that were not healthy.
Yeah, I mean, it's a culture where how things appear is more important than how things actually are.
Exactly.
So you want to appear successful, you want to appear wealthy, you want to appear accomplished, and sometimes striving for those things means they are reality. But there's a whole internal stuff happening, an interior life that we're not addressing. But why I think it really does inform your work is because in the book, a kind of recurring motif is the way that the Black women who are the character case studies, whether it's Maya or is it Miss Barbara, whoever it is,
Barbara,
they are just going and going and going. It's like this unrelenting engine.
Yes.
And it means they're not necessarily paying attention to their pain. And in your book, you write that in 2024, less than 7% of the entire NIH budget went to studies on women's health. And the vast majority of what was spent went to breast cancer and pregnancy research. Now, we know breast cancer and pregnancy research are really important and need to be studied. But there are so many other conditions that need to be studied too.
Yes.
You really focus in your book on 4 types of womb suffering. Can you explain to us what is womb suffering? And then I want us to just go through each of them for the audience at home.
Okay. Womb suffering to me is the inappropriate inheritance that Black women have received over generations of time. That teaches us to normalize severe gynecologic disease, up to and including cancers. And we learn how to do that because we're taught to normalize and neglect how we feel in service instead of being strong and caring for others. And specifically for womb suffering, that is then amplified and complemented by a medical system that is biased against us and also treats Black women, or I should say, doesn't treat Black women, neglects Black women as a norm. So you have both of those forces coming together, creating womb suffering.
You cited a study that said that, I think it was done in the 60s, that Black women came in with pelvic pain and they were incorrectly diagnosed with pelvic inflammatory disease, which is essentially a sexually transmitted infection. And just this idea that we are promiscuous. So any pain that we have is because of our own deviance. Is that something that lingers till present day, or have things changed somewhat?
Both and, yes, it absolutely lingers to present day. In 2016, there was a study of University of Virginia medical students and residents where I think it's like 24% of them stated they literally thought that Black people have thicker skin, physically skin, and therefore could tolerate more pain.
And you know the crazy thing? I believe there are Black people who believe that about
Oh,
themselves.
I'm sure.
Like internalize it. That
Absolutely.
our skin is so different.
Oh, we're so right.
The melanin makes it like vibranium.
Vibranium. Okay.
Yes. No, but like
I mean, yes, I get that too. Like we want to imagine ourselves
Yeah.
as well, right?
Yeah.
Like when you're so vulnerable in a society and you're constantly oppressed, you do want to like imagine yourself as stronger.
Superpower.
And we are strong. That's also the other issue. And you know, it's like the problem. That's why it's called a terrible strength. We are very strong, but then that creates this world in which Black women are also not taken care of.
Yeah.
We're not taken seriously. So that that idea back in the 1970s is when it was documented, absolutely persists. And I mean, it persists literally today when Black women are showing up and saying, I am in pain. The story of Jessica Petway, who was bleeding and nobody did an exam until it was too late. I mean, we continue to see it.
So I want to go through the types of womb suffering.
Yes.
Because I think it's like important to name the type of womb suffering it is, what it looks like, what are the risk factors for it, and what's the treatment or the next course of action for people at home. Because that's what you kind of do in the book. Like I love the book because you go down to the quote unquote basics, but a lot of women are not aware of their own anatomy.
Exactly.
We are not taught these things.
We have to start somewhere.
You know, and you know, it's something I was thinking about while reading the book. I don't want to spoil it, but there was so much intergenerational Black women's wisdom that told the people, whether I think it was Maya, periods are painful.
Yeah, it's fine.
Periods are heavy. Everyone, we all have them.
Exactly.
We all have pain. And so a lot of Black women have been told by their mothers and their grandmothers that stuff that's actually dysfunctional is normalized.
Correct.
And I like in the book that you're like trying to create a sense of a center and what's abnormal from that.
Yes.
So, okay. The first type of womb suffering is heavy menstrual bleeding.
Correct.
What is that? What does that actually look like?
Heavy menstrual bleeding is when, technically it's defined as you bleed more than you want to, basically. Like you bleed so much that it affects your quality of life. But if we want to get into more of the details, a normal menstrual period is only supposed to be about a half a cup of blood total.
I don't know. It never seems like half a cup.
I know. And the thing is, it does seem like more. However, sometimes I tell people that and they're like, wait, what?
Yeah.
And then I say, okay, let's use another metric. A normal menstrual period, you should not pass any clots greater than the size of a quarter or an inch.
Yeah.
That's another sign. You should not be having to change your tampon or pad more frequently than every 3 hours.
Okay. All right.
You should be able to basically make it overnight, like with an overnight pad. And not worry about like staining the sheets, et cetera, et cetera.
This is so helpful. So if you're a woman that worries about staining your clothes,
yes,
or the mattress,
you're doubling up on pads.
Okay.
Instead of using one, you're using adult diapers. You're putting things on the mattress because you want to protect your mattress because of stains. Also, if you have more than 2 or 3 days of heavy bleeding in your cycle, because most cycles should only have 1 or 2 days of heavy bleeding and then it goes away. Okay. Or if your cycle lasts longer than 7 days, that's another sign.
Okay, that's good to know because I have friends who have been like, well, I'm always on a period. And that happened in the book.
Yes.
Right?
Always on a period. Yeah. How many days do you not bleed becomes the question I ask.
Wow.
Because women are so used to, well, this is just my period.
So it should be 4 to 7 days.
4 to 7 days.
Maximum.
Yes.
Okay.
That's it.
And so what are the risk factors of like heavy menstrual bleeding? Because I'm thinking that, and then this is where we get woo-woo and can get into the wellness later. I have 2 daughters at home.
Yes.
And I'm like, I want to delay early puberty. I do.
I understand.
I'm thinking about the endocrine disruptors.
I do too.
And I don't like fat phobia and the culture, but I'm like, how can I keep their weight in a range that will ensure when they do start menses that it is tolerable? So like, what are the things that mean that a girl later in life may be at risk of heavy bleeding, or even a woman? Because I know I speak to some women and they're like, my period was like this before I had babies, and then after I had my babies,
it changed.
Yeah. So like, what are the risk factors for it?
Yeah. So one of the clearest risk factors is body size obesity. And the way I say this, because I agree with you, I'm not fat phobic, not trying to be, everything isn't obesity, but fat cells make estrogen. So they're one of the few places in the body where you can make hormone outside of your ovaries.
Okay.
And so because they make estrogen, they basically can like thicken up the lining of the womb and create more and more bleeding. It also creates a lot of irregular bleeding.
Okay.
So young girls who are obese, bigger at the time of puberty tend to have more problems with their menstrual cycle.
Got it.
Right. And that is the biological connection there. So that's one thing. In terms of heavy bleeding risk factors, we think there are a few things that behaviorally that can modify periods too, right? So you talked a little bit about like endocrine disrupting chemicals for the young kids. That's true. And we haven't quite pinned down specifically what that looks like. But diets that are that have high glycemic index, so like really sugary foods, like high calorie, simple sugars, terrible for hormone balancing because insulin impacts the estrogen. So that's another thing that will mess with your periods. I know this myself. Here's the thing. I know this myself. I'm like, I know I eat a certain way and I'm about to suffer.
Well, you know what? I think that's so interesting because like you mentioned in the book about like how there's something about not just blackness, but womanhood that kind of disrupts the mind-body connection.
Yes.
So there are some women that don't actually know that.
That's true.
You do talk about this.
Yeah,
about you
learn to dissociate. You just cut it off.
I think the quote is like, you learn how to take your head away from your body. Type of thing. Like these are separate things.
Exactly.
So a lot of people I don't think know.
That's a good point.
About the diet or if I have too much wine or
right. I feel, because I'm talking from where I am now. In my 20s, when I tell you I had French fries, a chocolate chip cookie, and a full calorie Coke for every meal, like I wasn't feeling anything. And I think that comes from when we teach girls that the most important thing about their period is to keep it a secret. So you start to learn it's nothing's happening down there, smile, laugh. You literally start to learn how to pretend through the pain. And so you disconnect. And so, we're not really connected to that at all. And unfortunately, what that means for Black women, though, is that we can be in the midst of severe gynecologic disease. And literally just be moving like everything's fine.
You mentioned the patient that you saw, I think, was it during your residency?
Yes, at Cook County Hospital in Chicago. Yes, she came in for a PAP. And I asked her the questions about her period, and I was very concerned about her answers. I just remember thinking, like, this sounds like you're bleeding way too much. So we checked her blood count. Her blood count level was 4. That's hemoglobin was the lab.
And what's it supposed to be?
It's supposed to be 12. Okay. 4 is like, if she was a patient in the hospital, I would have gotten an emergency page if she was saying, patient 16 is severely anemic, needs blood transfusion immediately. Like, that's how severe that is. And she was walking around, walked into the clinic. But the thing about that story is that when I called her to be like, girl, like you got to come back, your blood, she laughed at me. She was like, girl, we have strong periods in my family.
Oh my God.
It's fine. I got to go back to work. I can't take off work. And I just remember thinking, one, this is where that whole like Wakanda vibranium thing comes from. I had a moment where I was like, Black women are just like, who else could? You could never, you know? I mean, if she has a normal blood count, she would probably be an Olympian. This is crazy. But then also, how vulnerable is she? Christiana, think about that. She has just enough blood to just like barely be alive. She gets into a car accident, she's done. She doesn't have time for an ambulance to come. She might have one more period and that tips her over. She passes out. She could hit her head. Like all of these things could happen. And it's like, I think of it as this invisible vulnerability because nobody sees that from the outside. Yet we have just let her walk kind of on death's edge at all times. And it is profound to recognize that Black women live like this. And I'm just here because I don't want us to. You know?
So for the people at home that perhaps they've listened to you and they're like, I have heavy menstrual bleeding. What's the next diagnostic step? And what's the possible treatment? Because I think knowledge about treatment is so important because sometimes you don't know the options and a doctor can push you towards something
and you're like not really sure.
You're not really sure.
Doing this?
So what is the diagnostic step that their physician should be taking?
Absolutely. It should be a combination of lab tests and likely imaging tests and an exam.
And what type of imaging is it?
So usually you would start with a pelvic ultrasound because ultrasound takes like the best picture of the uterus. It's really nice up and close.
I love a transvaginal ultrasound. I recommend them to my friends all the time.
Okay.
I'm always like, get a transvaginal ultrasound.
Christiana, you're the only person I've ever heard say that.
I do.
Who is that? No, I love one too because I love the information it gives. But like I love
because
that is
getting
wonderful.
one changed my life.
Because you get so much information.
Yeah.
Anyway, so that is huge. There are over 80 causes of heavy menstrual bleeding.
Okay.
So I'm glad you said what is the diagnostic and then what is the treatment, because what happens and what a lot of people have experienced is they come with heavy bleeding and they don't experience any diagnostic period. Somebody just gives them some birth control.
They're like, go on
Here's
the pill.
birth control and that's it. And they get really upset. Okay, appropriately, because they're like, but why is this happening? So you should get labs. Those labs would be things like your blood count, your iron levels, your thyroid levels. Depending on the pattern of your bleeding, your hormone levels might be checked, especially your androgen levels. So that's one thing. In addition, you would start with like a history. Like there are things about your family history that might clue us in. For example, some people, Black women included, you actually have a bleeding history you don't realize because no women talked about their periods. But like, oh, so Uncle so-and-so had a clot and this person had a hemorrhagic stroke.
Yeah.
And
someone else had an aneurysm.
Yeah, and your aneurysm. And it turns out your family actually has a blood condition.
Yeah.
And the way it shows up in you is that you bleed a lot.
Okay.
So that's another, so we're going to ask a lot of questions and then we're going to do the imaging to look for what we call structural things. So could there be a fibroid pressing into the uterine cavity? Could there be a polyp, which is a different kind of growth that is causing the bleeding? Sometimes you have things on the cervix that you can't feel, but that are creating bleeding.
Yeah.
And then also there can be like ovarian cysts and things that are releasing hormones that need to be removed.
Yeah. I lost an aunt to cervical cancer.
I'm sorry.
Unfortunately. And it's something I talk about with friends about. I'm like, I feel like Black women have started surviving childbirth and now they're like,
here we are.
We talked about Jessica Pettaway, who cervical cancer, and the primary symptom was
bleeding.
But by the time she investigated the bleeding, it was really far gone. So it's so important as soon as something changes down there,
that's what
to see somebody.
As soon as something changes, it's like there's two things. One, your normal could be abnormal and we might be able to help you, but also, or we can help you. But also if something changes, it is reasonable to go get that checked out because that could be your early sign to intervene on something. You asked me about treatment, so I want to talk about that. Because we have a problem with how we talk about birth control, mainly meaning that we put about 100 different medications and formulations. We call it all birth control.
Yeah, everything from a coil to an implant,
to a different patch, to this, to that, including to medications that are actually designed mostly for gynecologic conditions.
Yeah.
They just happen to also be contraceptive and they all get put under birth control. So that drives me crazy.
And for Black people, there's a stigma when it comes to birth control, especially if someone says they want to put their teen daughter on birth control. You're like, oh, you're letting her have sex.
Exactly. And that causes a lot of trauma too, because people are like, my mother really thought I was promiscuous when I wasn't. So I think about managing heavy bleeding a few different ways. One is like stabilizing the uterine lining, because sometimes you bleed heavy because your uterine lining isn't stable enough. So the way that we stabilize the uterine lining is through use of progesterone in some form. In the book, I also give you some non-medical options. So
she's very woo-woo.
I'm very woo-woo.
So I give you that was me. She's like vitamin D, vitamin E.
Okay, I'm giving you all the options. However, progesterone is like the great endometrial stabilizer. So there are ways that we can do that. We can also suppress ovulation. So sometimes you just get so out of whack. It's almost like if you think of like a positive feedback loop where it's like every month it's just like more and more and more, and you got to interrupt it.
So you just reset.
Yes. And so that's why sometimes you will be offered birth control, which again, we'll call it what it actually is, combined estrogen and progesterone, because it's a reset. Okay. It's like, you know what? Y'all need to calm down. Y'all are all out of whack. We have to stop this positive feedback loop. And so it doesn't mean you're on it forever, but it can give a lot of information. Okay. So
I just want to ask a quick question. For Black women who have the BRCA1 gene, what are their options? Because I know that there are some within that population, especially there are Black women who have this gene, but they're not aware they have the gene, that having some sort of estrogen,
Yeah.
birth control puts them at additional risk, or maybe I'm wrong. What does it look like for that population?
We generally think that they have additional risk when we talk about menopause hormone therapy. So it's a little bit different.
Okay.
And so if you have the BRCA gene, or you have a lot of people, let's just say you have a lot of people in your family who've had breast cancer, if you have not been tested, then there are different protocols we use to assess like the risk. For example, you might have the BRCA gene, but not actually have estrogen or hormone dependent breast cancer in your family. So it's really not the hormone.
So it's actually the type. It's
the
a type within a type.
Exactly.
Okay.
So it's not as simple as that versus that. And ultimately, the things that make the most difference for BRCA carriers is actually suppressing ovulation, because that suppresses their ovarian cancer risk. And then also doing things like, if they're interested, things like mastectomy, tamoxifen, medication. There are medications that we can give them that also decrease.
Okay, so that's a separate category.
So it's a really separate category.
Because I know I speak to people at home, people in DMs, and they're just like, hey, I just don't know, because there is a cancer risk in my family.
Right.
And what options does that give me?
And that's why I'm like, go talk to a gynecologist, because they
actually... Oh, so that's gynecology, not genetic counseling?
No, that can also... So a gynecologist, in terms of finding out what the genetic risk is, a genetic counseling is important, or an oncologist. In terms of now what can I be treated with because I have this risk, gynecologist.
Okay.
And in fact, there are now a lot of oncofertility practices that are specifically designed to help people who have cancer risk but need some gynecologic guidance to help them.
Okay.
Yeah.
All right. So let's move to the next type of womb suffering, endometriosis. I love this quote. I'm going to read it to you direct. What you say in your book. You say, I see endometriosis as a story of migration, transformation, appropriation, and maladaptation. As the womb cells move around the body, their survival is prioritized at the expense of the larger organism, us. That's very poetic and wonderful. But in this really simple way, what is endometriosis?
In the really simple way, endometriosis is when cells that are very similar to the kind of cells that grow in our womb start growing in other areas of the body. And then they also start growing and bleeding like our womb cells would. So if you imagine, instead of just having a period inside your uterus that comes out the vagina, instead it's like everywhere these cells are, you have little periods where they're bleeding, creating inflammation, and that is why it's so painful.
Okay. You say how underdiagnosed it is, but how common it is, particularly among Black women. What are the symptoms of endometriosis?
Yeah.
Right?
Yeah. So we think it's about 1 in 10. It affects about 1 in 10 women in terms of how common it is. That's probably still an underestimate because so many people don't get diagnosed. So symptoms, one is outsized pain with your period, like extreme pain. And I have to, you know, like we have to give more context, right? Because people are like, what does that mean? I try to think of it as your pain is not controlled with regular over-the-counter medication.
Okay, so ibuprofen,
you take an
Tylenol,
ibuprofen, Tylenol, and it's like a joke. Okay. Number two, a lot of us are on our period. We're just like, you know what? I'm bleeding. I have to go to the bathroom all the time. I don't want to do anything. I'm just going to hang out on the couch. That's fine. Endometriosis pain is like, I would actually like to do things. I don't want to be here, but I cannot. Right? Like, if I try, I'll be bent over. I remember being bent over for 2 days. Just like my period was, that's outsized pain. Another one is a real severe changes with your bowel movements around the time of your period. And sometimes that can happen outside too, like when you ovulate, you'll notice it. And so we also look for that. So people who have severe constipation or severe diarrhea around the time of their periods, actually GI symptoms are super common in endometriosis. If your very first period was painful. So interesting. Yes. Most people, their very first period is like, it's surprising, right?
But it's very light.
But
it's not even a real period.
Yeah, it's like a little do, right? And you bleed and like whatever. But if it's painful, if it hurts, that is another sign of endometriosis.
Oh, okay. So this is helpful to go to
for the mothers and the daughters.
Yeah, the mother and so what are the risk factors of that initial first painful period and going to women? Because there are women that experience the symptoms that you have, but they may not have endometriosis.
Yeah.
So what makes you, as a doctor, someone comes in and says, hey, these are my symptoms. What makes you think endometriosis as opposed to something else?
That's a great question. A lot of women with endometriosis also have pain outside of their cycles. So they're like, yes, my periods are the worst, but even outside of that, I have just like constant pelvic
So pain during
Yeah,
sex.
we call pain during sex. We call it non-cyclic pain, basically. Yes, which I also had. And you know what, Christiana? I thought, oh well,
Sex is supposed to be
hurts.
painful.
Ugh.
Yeah.
Yes. So risk factors for that's what you're asking. Risk factors for
Yeah.
endometriosis. Low birth weight at the time of being
Wow.
born. Who has the highest rate of low birth weight babies?
Black
women.
women. Yeah.
Yes.
Because of the stress.
Yes. A baby that is also, we call it small for gestational
And so
age.
what's considered low birth weight, by the way? Because I know that's like a cultural, because
It
sometimes
is.
even relative to your family. Like in
Yeah.
my grandma's lowest baby was 10 pounds.
Okay.
No,
Yeah,
but I
it
mean,
is.
it's
No,
really,
that's a good
so what
point.
is low birth
Low
weight?
birth weight is actually dependent on like how, like what day you're born. Like if you're 37 weeks, 38 weeks,
Okay.
40. So it's not
low,
one threshold.
Low birth weight according to
gestational age.
Okay.
Exactly. So low birth weight. And then also being what we call small for gestational age, which is like, it's a very similar construct. Those increase risk of endometriosis. You know what else does? Childhood sexual and emotional abuse.
Okay.
And that's where the woo-woo comes in for me, at least.
Yeah.
Because I'm like, our bodies are connected to our experiences.
I agree with you completely.
And this silencing, it has to go somewhere, you know? So that's another risk factor for endometriosis. Those are the main ones.
Okay. In the book, you go into the diagnostic element,
Yes.
right? And I think this is really important for people at home because your feeling is that there was a gold standard for diagnosis.
Yes.
And that's no longer happening.
Yes.
And that's harming Black women the most.
I'm concerned. So this is like hot off the press too. So when I wrote the book, the gold standard for diagnosis was you had surgery. Somebody has to look inside your belly to see those womb cells outside of the womb, basically be like, okay, here it is. This is endometriosis. Why? It's because a lot of these symptoms could be caused by other things. You want to make sure you're not missing anything. So that was what we say. Okay, now we're certain. You could have suspected, but now we're certain. The other thing is that oftentimes that surgery is paired with the treatment. So like you're going in, you're seeing the lesions and saying we're certain, and now we're going to remove
They're
them.
like scraping.
And let's scrape them off
Yeah.
so that we're also giving you relief. Now, like very recently, the American College of Obstetrics and Gynecology has shifted to say that endometriosis can be diagnosed just by clinical suspicion, which essentially means your doctor believes that your symptoms and your pain all fit endometriosis. And so if that's the case, then we're going to call it endometriosis. And as a Black woman, I'm like, okay. So if now it's dependent upon me to convince my doctor that I fit these parameters, how is that going to create? I'm worried. I'm not saying it is. I'm just worried it's going to create a new disparity or discrepancy between who gets endometriosis treatment when, right? And like who gets access to it when. It's not a small thing to tell Black women, just convince them. Okay. That's all I'm saying.
All right. That's very useful because that brings us to the treatment part, right? Because, you know, I know women who have had hysterectomies very young because of endometriosis. And that was their choice. They were like, I cannot live like this.
Yeah.
They got the hysterectomy. Some of them, that resolved their pain, but for other them, it was so advanced. Disease was so advanced. They've had to have bowel resections. They've found it in their lung.
Yeah,
it's like
everywhere.
Everywhere, right? So there is hysterectomy. There are, you know, some women, I think you mentioned Lupron, which is...
Yep. They can take kind of like a
Lupron.
hormone suppressant, a GnRH
But
agonist.
I know for some of the girls back home are very woo-woo. They're like, what are the lifestyle modifications that I can do while I wait for that diagnosis? Because I think you mentioned it's the illness that takes the longest to diagnose.
Yeah, 4 to 7 years. Although a lot of that is because people aren't believed. So that's hopefully that is getting shorter and shorter. I love this question because I think everybody wants agency. Everybody wants to feel like I can do something even if I know I eventually might need some kind of surgery. So first of all, there are vitamins that help with endometriotic pain.
Okay, tell me.
So vitamin C and vitamin E.
I can hear people at home putting them in their
both,
Amazon cart right now.
Okay, I as a woo-woo girl with a scientific heart of gold, I like to see some kind of studies before I recommend anything. And those two have some pretty decent studies about decreasing certain types of endometriosis pain.
So is it reducing the inflammatory response? Like
probably. Okay. We think it's through an anti-inflammatory mechanism. Melatonin, interestingly enough, 10 milligrams a day, can also, in a trial, has been shown to decrease endometriosis pain. When you start to talk about that's pain. When you start to talk about treating endometriosis, like trying to treat the lesions and get them to resolve, remember that the pain of these lesions is driven by inflammation and a hormone signaling process.
Mhm.
So it would make sense, right, that our primary treatments are anti-inflammatory and hormone modulating.
Mhm.
Okay. So the way that we treat the lesions themselves, there are 2 actually oral medications now that were specifically formulated for endometriosis to decrease lesions and decrease pain. And they are the combination of those 2. They both deal with the hormonal aspect and the anti-inflammatory aspect. So those are the kind of options that you have on the table while you're waiting for your appointment and you're doing your vitamins that you can access to. And those are oral medications, right? That's not surgery.
Yeah.
Or something more invasive than that. And then, like you said, there are the stronger medications like Lupron, which we tend to just give either pre or post surgery to help with that. And then there's the surgical excision and removal. I want to say something about hysterectomy that I think is really important.
Yeah.
Because there was a time when, unfortunately, some women were getting inappropriate hysterectomy. Endometriosis is really the fuel is from the ovaries, not the uterus. And a
Oh.
hysterectomy is just removing the uterus. So, for endometriosis, we try to be careful so that we don't have women going just to get their uterus removed and their ovaries are hanging out because those will still create the fuel. And so it's a very careful conversation for somebody because often if they really need the symptomatic relief, often we're talking about removing ovaries, which is surgical menopause.
So it's a full hysterectomy.
Yes, and removal of the tubes and ovaries.
Okay.
Yeah.
I would, for that mother at home who
Uh-huh.
has a young daughter who has had that first painful period.
Yeah.
Maybe she's 14, 15, having painful periods.
Yes.
And you've said that the first painful period is an
That is
indication.
an indicator, yes.
What can she do to perhaps interrupt that loop?
Yes.
Is there anything?
Sure. First of all, she should see a pediatric and adolescent gynecologist.
Okay.
These are gynecologists who did extra board certification specifically to be able to treat like teenagers with endometriosis and various other things.
I didn't even know that existed.
Exactly. That's why I tell
know.
like gynecology, we have a long way to go to improve.
You guys need to do more branding.
People
need to know.
Our branding is horrible. Like we don't communicate. Like most people are like, I didn't even know that existed.
Yeah.
I'm like, yes.
Yeah.
There's a wonderful gynecologist online, Dr. Cherish Chambers. She's at The Period Doctor. She's great. But so that's one thing. What will then happen is basically a discussion about how do we want to approach this? And it might start with maybe we don't want to start hormonally. We're going to start with an anti-inflammatory protocol. So you can have access not just to over-the-counter anti-inflammatories, but prescription anti-inflammatories, not narcotics, right? But just to say, okay, let's see how much benefit there is here, if it's worth it or not. There are pros and cons, right? Or you might start with like a low dose of a smaller, especially weight-based dose of some of the hormonal medications, again, to interrupt the loop, to say, we really need to calm this down because, Christiana, the longer the endometriosis goes, untreated, right, you're getting more and more lesions, more and more inflammation. That inflammation turns into scar tissue. Yeah. And now the scar, you can't treat, the scar tissue is just scarred. So that the only thing for that is surgery. So I really want us to think about these medication options, including when we're like, I don't want my daughter on whatever. Do you want her to have surgery in 10 years?
And I think also it's thinking about her reproductive journey because I think if one of my daughters was in that position, I'm then saying, okay, when you're 17, we're freezing your eggs. You know, it's that type of reproductive counseling because like just bank them just in case, because I think endometriosis causes huge issues with fertility, and not just getting pregnant, but staying pregnant.
It can definitely cause issues with fertility for sure. And I know a lot of the physicians who work in the egg freezing space are like moving towards this, like maybe the early, like we just want all the early 20-year-olds to like freeze your eggs because A, B, and C. But I didn't even learn that I had endometriosis until I was on the table for my C-section.
Wow.
I had gone through infertility workup. And I remember when they asked me, are your periods painful? And I literally remember saying like, I mean, they're bad, but like, you know, I can handle it. Like, it's not like I'm laid out because I didn't have an option. There was no option for me to be laid out. So I agree with you. I think that in gynecology, we've had so many decades and so much history of such paternalism that we are so behind in giving women agency by giving them information and saying, hey, you could think about this differently going forward. that is a lot of what my book is about too. It's like,
Mhm.
if you know, now you can take your vitamins, you can have
Yeah.
options. And then also you won't necessarily be so afraid of or just repelled by treatments that are actually very good, but unfortunately have been given in the wrong context.
Given a bad name. Okay.
Yes.
So the next type of womb suffering, fibroids.
Oh, girl.
What are fibroids?
Whew.
What are the symptoms and risk factors?
Yeah.
What's the treatment?
Fibroids are tumors.
Okay.
Smooth muscle tumors. Why do we say smooth muscle? Because the uterus has 3 layers. Forgive the anatomy lesson. We got to do anatomy for a second. It has 3 layers. It has an inner layer, which is the endometrium, which is what bleeds. It has an outer layer, which is like the serosa, which is like the wrapping paper. And then the middle layer is the myometrium, which is muscle. It is a muscle. That's the muscle that contracts, that squeezes together when we have a baby, et cetera, when we have a period. Those muscle cells, a fibroid happens when one of those muscle cells, just one, gets a mutation and starts growing aberrantly. So it grows too much extracellular matrix. It's not an ordered, the muscle cells aren't ordered. They're like all a big blob, and it creates these balls, these hardened, often calcified balls in the wall of the uterus. Those are what fibroids are. Okay. So why do those little point mutations happen? Still figuring it out. Not sure. There are lots of different inputs though, because this is what kind of drives me a little bit crazy about the fibroid discourse, is that there's not one cause of fibroids. Like there are a lot of different mutations.
And they're
that
really
can
in the
happen.
news right now because Lupita has
I
really
know.
bravely come forward and
which I am so grateful
and she
for.
said the fibroids are back.
Yes,
she dealt
and they
with
come
them.
back.
Okay,
yes, and they can come back. Exactly, because especially if you don't get all of the stem cells out, the disordered stem cells that start growing fibroids, they'll grow back, and then also you can get new mutations, new growths. Things that so first of all, most women have fibroids. That's important to start with, okay?
70%, when you say most,
80% of Black women, 70% of white women.
Oh, I didn't even know white women got fibroids.
70%.
Wow.
White women tend to have smaller fibroids that are not as symptomatic, and they also have fibroids that tend to regress more during the menopausal years. Black women start getting fibroids earlier. Our fibroids grow bigger, and they tend to last longer and through the menopausal years.
And so why is that?
Racism.
Okay.
I mean, figuring it out is like, we don't know the answers.
But I mean, I think.
But I can tell you what we do know.
Yeah, what do we know?
Okay, so there was a study called the Black Women's Health Study, where they enrolled over 50,000 Black women. They followed these Black women for over 20 years. They specifically looked at their fibroids, how they grow, and what those Black women were doing, their lifestyle factors. So they found out a few things that I think are helpful. One, alcohol increases risk of fibroids.
Oh,
I know,
God.
I'm sorry. The good news, though, is that it's beer over liquor.
Oh,
okay, right, exactly. Every Black woman is like, okay. So that's I apologize, but it is true. Okay, so another thing that they found is that, again, we come back to high-fat diets, high glycemic index, bad food that you're not supposed to eat.
Insulin resistance.
Insulin resistance. It's all the same thing. That also increases risk of fibroids. Interestingly enough, for women who have children, so women who've had children, gaining more than 20 pounds since the time you were about 18 or 20 increases risk of fibroids.
Okay.
That is likely because of that estrogen that we talked about. So that's another thing. However, if you haven't had kids, there's not really a relationship, which I thought was interesting.
Is there, is there any relationship between fibroids and the risk of breast cancer? Because this is something me and my girlfriends have been talking about.
Not that
Among
I
Black
know
women.
of.
Okay.
No, I think fibroids are so common that
I just like, if you're a Black woman that has fibroids, does that increase your
no,
breast
that doesn't
cancer?
increase your risk.
Okay.
Risk
Maybe
of
I've been
breast
reading
cancer.
too much Dr. Sebi.
Oh my God. No, see, now you're trying to trigger me. No, it does not.
Okay.
Okay, so things that are not related to fibroid use, birth control. So when I tell you I pored over the literature of this, because I know how strong that feeling is that it's the birth control, it's the birth control. What it is that fibroids start growing in Black women in like our 20s, like 20, 21, 22.
Well, do you know what my thing? You're going to be like, get off this show, Christiana. I think it's the hair relaxers.
Okay, so we've studied this.
Okay.
We've studied this.
All right, tell me.
So chemical hair relaxers we think increased fibroid risk, the estimate is about 17%.
So it is the relaxers.
That's very small.
Okay.
But it's still, it still increases.
You said 17%.
17%.
That's a big percentage to me.
That's a relative percentage.
If someone said to me, you have a 17% risk of dying tomorrow.
But that's absolute risk.
Okay.
I'm talking about relative risk. So 17% risk is like going from, 10% is going from like 50 to 60.
That's too much.
Okay.
Listen, I'm a hypochondriac, so that's too much.
Okay, so it does. So we do have that. It doesn't explain the huge differences that we see, but yes, we do.
Okay.
So the data is there. So that contributes. We think also there's air pollution. So there are some certain components of air pollution that increases risk of fibroids that are more common in where Black people live. Okay. So that's another element. I'm trying to remember all the things. The rest of it are in the book.
Yeah.
I mean, there's a lot.
You mentioned this thing called anger squelching.
Oh my, thank you. Okay.
Yeah.
So let's talk about the emotions. I read this paper like 3 times because I was like, oh my God. Yeah. So we talked before about how like childhood sexual and emotional abuse increases risk of endometriosis. So emotions are also, they seem to be associated with fibroids as well. So there was a study led by a Black woman, Dr. Anissa Vines, and she basically looked at women who did not have fibroids. And she looked at this measure of something called anger squelching, which is basically like when you're angry, but you suppress it. Oof. You have to push it down. And so they looked at like, do you do this once a day? Do you do this once a week? Do you feel like you do this every day, et cetera? And the women who were the frequent anger squelchers, like I am pushing down all the time, had the highest prevalence of fibroids. It was associated
and it's so paradoxical
with fibroids.
Because they say we're angry, but the reality is we're squelching our anger so much that it's giving us fibroids. It's making us sick.
Literally making us sick. And, correlation is not causation, whatever. But like, this is where my woo-woo comes in, where I'm like, but I can also recognize patterns. And like, that is, when you see data like that, you're like, okay, so let's not be so shocked that 80% of Black women are dealing with fibroids. Like, this is our life. Okay. So when I talk to people about like emotional health and like processing your emotions and like being like, that is real. That is also about your womb health too.
And so that leads to like the diagnostic and the treatment element, because what does that look like? The road to diagnosis and the treatment? Because a friend of mine went to an OB who treats mostly Black and brown patients, and he used something called UFE. Like he injected like a dye. So there's all types. It doesn't have to be a myomectomy or hysterectomy. There's all types. The medicine is moved forward a lot.
Yeah, and this is where honestly I think I might be a little bit outside of the norm of my field, in that I think it's helpful for people to know if they have fibroids, whether they are having symptoms or not, because it gives them more options, one, of some of the holistic stuff we talked about, and two, it also just helps them identify earlier if they do need intervention when they have more options than a major surgery. Okay. So we've got a few things. So there's something called a hysteroscopic myomectomy, which is a big word, but basically it's when the fibroid is like sticking into the uterine cavity, it can cause so much bleeding. It could be like 2 centimeters be causing all this bleeding. We can actually go up into the cavity and just resect it out. No incisions on your belly at all. Often can be done in the office. There's also, for fibroids, there's also something called uterine fibroid embolization, which is what you were talking about. That's done by a radiation oncologist. And that's where they go and they basically cut off the blood supply to the fibroid by basically just going through your veins. Like they just go through your veins and they cut off the blood supply, and then the fibroid slowly dies on its own. Now, it's important to know that sometimes that death process can be painful. So that's uterine fibroid embolization. Then there is also myomectomy. Myomectomy is when you go in and you're just taking out the fibroid and you're leaving the uterus. And you can have that done in like a big incision or small incisions.
Yeah, I think I've a lot of Black women that I know, when it's been in my family, because they work, they cannot do the big incision.
Yeah. So the laparoscopic myomectomy. And then of course there's hysterectomy. There's also something that's not used as much called there's something called MR guided ultrasound ablation, which is basically like they use a much more powerful ultrasound, and it's like it's very Wakanda, like beams. Yeah, they like blast it, like Shuri's little blasters, and they like blast the fibroid and it breaks down. And then there's something called radio frequency ablation, which does usually it goes together with surgery, which basically like you have a surgery laparoscopic, and then they can put these ablaters in and then ablate the fibroid that way.
Okay. All right. Now you need to help me, Dr. Kemi, because I still can't figure this out. And this is me being in Dr. Sebi world.
Okay.
Is it possible to shrink fibroids apart from the UFE?
Okay.
When people say, I am trying to naturally shrink my fibroids, and sometimes it's stupid stuff like they're sitting over like salts and yoni like that's not going to work. But then some people like diet.
Yeah, let me
can fibroid shrink? Because and this is not me even trying.
Yes.
When I started fertility treatment, I got an ultrasound and it showed a fibroid on the exterior. I've got an ultrasound somewhere else and there was no fibroid. And I was like, but I have a fibroid.
Yeah.
So it was like the fibroid vanished. I didn't try and do anything, but I'm just talking about my own experience.
Yes, yes.
Can they be shrunk?
Yeah, so I think I'm going to start by telling you a statistic that's going to influence my answer, which is that 50% of fibroids go away on their own.
Oh, just without any intervention?
Yes.
Okay.
So when you're talking to people who are like, I shrunk my fibroids, I did it, girls. This is the protocol. I have the data. Half.
It's just life. It's just life. Okay.
So 50%. So let's just say that. Now, the ones that are least likely to shrink are going to be your ones that are 4 centimeters or greater. So they can still do so, but when they get that big, usually like they hang it around.
Okay.
So
that's stuff you can do to kind of stop their growth, stabilize.
That's what we're about. Yeah. So vitamin D has very good evidence, not just in Black women, in other populations. Many times people have looked at this. Vitamin D has very good evidence for stabilizing fibroid growth. It does not shrink them. But it does stabilize growth and tends to prevent more fibroids from coming on board, which is why, again, it might be helpful to know if you have them, if they start growing on people in your 20s, because you can be like, okay, some of these might go away. And for the other ones, let me pop my vitamin D.
That's very helpful because you talk about the agency. It's like giving people agency.
That you have. Yes. Otherwise, Lupron, so GnRH agonists, that's the kind of medication, they will shrink fibroids. That is one, yes.
And how long would you have to be on Lupron for? I know it's how long is a piece of string,
3 to 6 months.
Okay, so that's,
but when you go off of it, then they often will grow back. So people can use it though to have the surgery when they want. So maybe it's like your fibroid is too big for a laparoscopic surgery, but if you do the Lupron and shrink it down, now we can do this smaller surgery. Yeah. So we tend to use it more like that.
Lupron's such a powerful drug. I was on it when I did IVF, and it's like it's not an easy thing.
It's not an easy thing,
but it works.
Yes, and if it's important to you, it's an option.
Okay, so the final type of womb suffering you identified is probably the heaviest part of the book. It involves Miss Barbara, whose journey is just incredible. Who is one of your patients?
Miss Barbara, yeah.
And it's endometrial cancer.
Yeah.
So what is endometrial cancer? What are the risk factors and the diagnostic steps? Yeah. And then what is the treatment? And I really think we need to talk about treatment because you have had to treat patients who have been like, I want to treat this with like vitamin D and green juice, and they have later died, unfortunately. Yeah. So among Black women especially, there are people choosing alternative paths. I mean, we had Ananda Lewis, and there are real consequences. So I want to talk about all of that.
Fantastic.
Yeah.
Endometrial cancer is a cancer of that inner lining of the womb. So I tend to just say womb cancer or uterine cancer because it's easier, but that's what endometrial cancer is. Endometrial cancer is on the rise. We are seeing more and more and more. A few reasons. One, there are less hysterectomies, so more women have their uterus longer. Okay. 2, obesity epidemic. Obesity is a major risk factor for endometrial cancer, but not the only one. And also in Black women, it's not as strong of a risk factor. So like for Black women, it's more of our reproductive factors like irregular cycles, early first period, things like that. And then the third reason we don't know, like we're trying to figure it out. But the bottom line is it's on the rise. It is 1 in 32 right now women will be diagnosed. It's the #1 gynecologic cancer. It's 4 times more common than cervical cancer. This is why I'm glad we're talking about it because to me, it's like this silent epidemic that nobody is talking about.
I didn't know that at all.
Right. I mean, Gwen Ifill died of endometrial cancer. Yeah. That's like the one person I think that we really hear about affected. So I personally, it means it's very important to me because Black women are twice as likely to die if we get this cancer compared to everybody else. And that is worse than breast cancer, worse than colon cancer.
And you said it's very treatable if
very
found
treatable
at the right...
if found early. I'm sorry. Bring me back from the darkness.
So, no. But I think that's why I think that's the tragedy of it. It's like a cancer that no one should really die from at this point.
Exactly. Okay. So So yeah, when we catch it early, we have a much better chance of cure. It's not 100%, but it's way better than when we
Okay.
catch it late. The most common symptom, so endometrial cancer tends to come on in the menopausal years. So
Okay.
the average age of diagnosis is like 63.
But you say Black women experience menopause earlier, right?
Exactly. So
Okay.
Black women experience menopause earlier. So Black women are going to be diagnosed anytime between 50s to 70s, mid 70s with
Okay.
endometrial cancer.
Relatively younger than the rest of
A
the
little
others.
bit younger than the rest of everybody else, but it's more that because Black women have longer perimenopause symptoms, there's more confusion of when endometrial cancer shows up.
Do you know what? I'm so glad you're saying this because everyone on Instagram thinks they have perimenopause, but they can't all have perimenopause.
Do you want me to get in trouble?
No, I wouldn't. Yeah, at least let it be you. Normally, I'm the one getting in trouble, so let it be somebody else.
You know,
No, but it can't all be
two
perimenopause,
two
right?
things can be true. You
Okay.
know, it's like we always knew about perimenopause. Apparently, again, gynecologists, bad communicators. We didn't tell everybody else about it.
But like a 40-year-old should not yet be in perimenopause.
Oh no, a 40-year-old can definitely be in perimenopause.
It seems that everyone who's 40 is in
Everybody who's 40 is not in perimenopause.
Okay.
A lot of people in 40 are just aging.
Yes.
So in the absence of perimenopause, there are also aging-related changes that happen to us. And so disentangling what those two things are is something that I think maybe there's less interest in right now. And so everything is perimenopause.
Mhm.
But yeah, a lot of it is aging.
Okay.
Women of color are more likely to have perimenopausal symptoms earlier, like 35 and up. But
my
yeah,
God.
not everything is perimenopause. And plenty of women don't even have a single symptom until they're like 53.
By the way, I thought I had perimenopause. I was pregnant.
Okay, thank you. I'm glad you pointed this out.
I was
Because sometimes I'm like, girl, is it perimenopause or are you pregnant?
I was pregnant. I was just like,
Exactly.
well, then I also thought I had Hodgkin's lymphoma because I had night sweats.
Okay.
So I was like, I called my money guy. I was like, get my house in order.
Right. This is it.
My friends are like, no. I was like, this is it. And then I was pregnant.
And you were pregnant. And this is the problem with the discourse because I'm like, everybody should still be taking their pregnancy tests because not everything is perimenopause.
I was pregnant.
Okay, so yeah, so if it impacts women in their menopausal years, so the number one symptom is actually after your bleeding has basically subsided, like it's really come down.
Mhm.
You haven't had a period in 9, 10, 12 months, you bleed again. And it usually is not a full period. It's usually like a little bit of spotting, something you would be like, that's weird, and keep moving. Number one sign of endometrial cancer. So what do you think happens with Black women?
So this is after you've
finished menopause. Now, you could still have menopausal symptoms. You could still be hot
But how do you
flashing,
establish you finished menopause?
It's been 9 to 12 months since your last period.
Okay.
So let's say 12. It's been 12 months since your last period. You're not supposed to have any more bleeding.
Okay.
Then you have bleeding again.
That's good to know.
That's postmenopausal bleeding. That's the number one sign. So most women get that with endometrial cancer. Most of them get it when they're stage 1, early, or even pre-cancer. Like the precancerous cells will start doing that. Then what happens is you go tell your doctor listens to you. I had some postmenopausal spotting. And then they do a biopsy to see what's going on in the uterus.
So that's the diagnostic step.
That is the way to determine if you have the endometrial cancer.
Okay.
What has happened is that ultrasound can also be used to basically say, like, what's the likelihood, though, you have this? Because maybe we don't need to biopsy everybody. But that ultrasound technique does not perform as well in Black women.
And why is that?
Because of the level of fibroids that are bigger, and because of the type of endometrial cancer that Black women get is a more aggressive type that doesn't cause the same sign on ultrasound. Okay. And so that was what my research was showing, is that we were systematically missing this cancer in Black women and delaying their diagnoses. So I tell Black women, if you have postmenopausal bleeding, you need to get a biopsy to find out what it is. It doesn't mean it's 100% cancer, but it's a sign. It's like if you had a breast mass. It might not be breast cancer, but aren't you going to go check it out and see? Yeah.
Okay. So, and the treatment.
So treatments. Yes. So if we catch endometrial cancer stage 1 and it's very early, often all we have to do is a hysterectomy. And it's
nothing, and you can move on with your life.
Yes. Wow. If it's stage 1 and it's low grade, like not aggressive, hysterectomy. Yeah. Now, there are some types that are more aggressive, or if it's stage 2, 3, if it goes on further, we still have like 70% cure rates. So it's not a death sentence, but you have to do the treatment.
So why is it a death sentence for so many women? If Black women, if that's stage 2, 3, it's still very curable?
Because One, Black women get more aggressive cancers, which is why we especially need to be diagnosed as soon as possible.
Okay.
And then number two, Black women are less likely to complete their treatment.
Why?
Because it's hard to go through. We're isolated. This is another part of my research. And we bargain. So we're like, well, 6 cycles of chemo. They wanted me to do 6, so I did 4.
Okay.
They wanted me to do chemotherapy and radiation. I said, I'm going to do one or the other.
Mm-hmm.
It's too much on my body. I understand these things. But as the oncologist, it is heartbreaking to see somebody leave treatment on the table when you know that's what they need.
Okay. And so what can we do as a community to encourage people
to go through their
to
treatment?
Follow what their doctor is saying?
Yeah. I think one thing to know is that, especially for I told my patients this all the time, especially for endometrial cancer, the 2 most common medications we use, carboplatin and paclitaxel, have natural origins. Paclitaxel comes from the yew tree. It has been used in different civilizations for a really long time. And now we are able to synthesize it so we don't have to cut down those trees. Carboplatin comes from literally the element platinum, from the periodic table of elements. So these are not things, these are things that the earth has given us that help us now treat this cancer.
You said, my friends, my real woo-woo Hebrew Israelite friends are going to love the fact that you said the earth has given us
these compounds. We can use them.
Yeah.
So I would say that. The other thing I would tell them is that they don't have to go through it alone, and they shouldn't actually. Isolating yourself during a cancer treatment is independently associated with mortality because your body is not supposed to be going through that level of stress by itself. So you actually need to surround yourself with people who won't just bring flowers and be like, good luck, but actually have a community of people who will be around you. There is an organization called the Endometrial Cancer Action Network for African Americans that is literally all Black women who've been through it. And so they will walk beside.
So there's resources out there.
There's resources out there. There's information out there so that you or your loved one don't have to go through it alone. And I firmly believe. Also, there's a lot of research on treatment. So now we have a really good immunotherapy medication for endometrial cancer, which means that the medication tunes your immune system to go fight the cancer itself. And that has significantly improved our success. So I try to say, I think on the oncology side, we're doing everything we can. All the research is happening. On the Black woman side, what I want all of us to do is be aware of what's going on with our womb health. And when something is not right, like you have spotting when you were not supposed to, you are in that doctor's office. You come early, we work on the treatments.
I want to talk to you about a couple of things before you go, because this has been so great. The version of this interview I've done, we've gone through the womb suffering, we've gone through what they are and the diagnosis and what it looks like, but it kind of assumes that the women at home are dealing with medical professionals that not just believe them, but have the time. Because, my mother-in-law is a doctor and she cares so much about her patients. She is seeing so many patients, right? So you're dealing with people that care, but institutions that are not equipped. And, people are time poor. In the book, there are so many examples of people like, oh, I got to go to work.
Exactly.
I got my kids. I got a sick parent. So there are all of these structural forces that mean diagnosis is really hard.
Yeah.
What would you say to women to A, get doctors to believe them, and B, just navigating the medical system without that real fatigue? Because I'm somebody who considers myself very educated, and there are things I put off because I'm just like, I don't have capacity right now. What would you say to them?
Oh gosh, I would say that you're right. You actually can continue to endure. You deserve more. You deserve better. And actually every single person around you that's relying on you and the whole world that expects more from you and all of that stuff will also be better off when we Black women decide that we are not going to put the womb health in the category of things we just endure. We know how to demand space and respect. And I want us to feel that same way when it comes to womb health. It's we refuse to accept low quality here. I would also tell people a symptom diary is really important. 3 months, I just want you just document. If your periods are super normal, you got no problems, great. You have a 3-month record. Now when something changes, it's clear. You don't have to go wait, was it this? Was it that? We are horrible at memory. We think we're good. We're terrible. you've got to write things down. Number 2 is when you go to the doctor, start with the most important question. Don't this whole, I'm going to start here, then go. No, you like open with the problem so that your visit is really focused on that. And then I talk about these different things in the book, like the literal vocabulary you use signals different areas. So Black women, I know we are so good at adapting. So if somebody says, well, are you able to work? What's the answer? Yes. But what is the adaptation you've made to be able to work? Well, I can work, but I have to keep 3 stashes of pads in my thing. I have to wear an adult diaper if I'm on my period. Those are adaptations that are far beyond the pale. So being able to say things like, I am no longer able to do my regular activities without insert adaptation changes the game. Because now that tells us you can't do your activities of daily living. Another like vocabulary piece that I think is important is this is not my normal. And this is where that symptom diary comes in, because it's one thing to say like, I don't know. Yeah, I feel like my periods are just heavier. I'm not sure. It's another thing to say this was January through March. And this is where we are now. Something has changed. This is not my normal. In gynecology, there's so much variety in people's periods just normally. You know, some people have 24 days, 27 days between cycles, all that. So for you to be able to be clear to say it was A and now it's B also is a signal to us something has changed to look into. Another question is, what is the differential diagnosis? Or that's like the medical term, or like, what are the options, or what are the options you're thinking that could be the cause? Okay. That clues you into something that physicians are doing, which is thinking, okay, is it A, is it B, is it C, is it D, is it, okay. There's over 80 causes of heavy bleeding, 80. So we have to sit there and think about, okay, which one do we think this is? And then how would we treat it? And then the last thing, there's more in the book, but the last thing I'll end with now is such an important question, which is, what is the follow-up plan? So at the end of the visit, right, you're either going to have, okay, we're going to do these tests, or we're going to try this medication. I tell people, do not leave without the next appointment. Literally don't leave.
But you know, the thing that, and you know, you mentioned it in the book as a thing people experience, there are a lot of doctors that don't follow up.
Exactly. They don't follow. Yeah.
Even if they have a follow-up plan.
Yeah, so you have to follow. That's what I'm saying.
So you were like, you have to be on, the follow-up plan is about you.
Yes, I am the follow-up. So it's like, thank you very much. I'll see you in 3 weeks. Okay. Like, I'm coming back to see you in 3 weeks.
Coming back to that agency.
Like, yeah, it's just, we don't, I can tell you from the physician side, the world of like, I'm going to call my patients and this and that, like I cannot express to you the time pressures are intense. So you need to be the, what do they call that? The squeaky wheel. Like you back in the office. Hi. Yeah. I was in the 2 weeks ago. Let's talk about the follow-up plan. So that's also important. I also really think that we shouldn't go to the doctor alone. I mean, if you already know your doctor, you guys have a great relationship, especially when we talk about gynecology, fine. But if it's the first time, the first few, you need to bring what I call a womb sister, somebody who you trust, who you can share like what's actually going on with you.
Especially if your symptoms are severe and it's been serious, having somebody alongside you.
There because it's just, you know this too, when you're a patient, you're so vulnerable. Like it's crazy how clear you can be. And then you walk into the office and like.
Also, it's the area.
It's very the area.
You're like, you know, are you going to do a pelvic exam? Are you, like a lot of that is you feel very exposed. As someone who's had like 3 kids, you know,
agreed.
I know women who have had their babies. They're like, I've been so traumatized from all the cervical checks. I cannot see a gynecologist. I don't even want to see. Yes, exactly. Like that's the thing that my field has. We're doing better, but people come in with so much trauma from their prior visits. Pap smears. I have friends who like after their first pap and experience with a speculum, they're like, never again. Yes, never again.
Yes, I was one of those people who had a really terrible first experience with gynecology. So it's okay to bring a friend. It's okay to bring somebody who, even that person might not even say anything. You might just be like, you know what? I just want you to be not even a witness, but like another perspective. Yeah. Because maybe you might feel this doctor's great. And that person is like, okay, he was really nice, but he did not say anything.
They need to hold space.
Yes. They need to hold space.
It is. That's what holding space is.
They need to hold space, and if you trust them, then you have just something outside of you. Because let me tell you something. Yeah. A great doctor is not a doctor that's always going to tell you what you want to hear.
Yeah, yeah.
So you need somebody who can tell you the difference between, well, I don't know, he's not listening to me, whatever, and girl, he's listening to you. He's not
Yeah.
giving you the answer you want.
Yeah.
And those are two different things.
Yeah.
So I think that that's also very important, especially as we're moving hopefully back in mass into gynecology, because that's also what changes the quality of care in the field.
That point you made about the doctor not saying what you want to hear, I think that happens a lot with our community who have this very complex history with the medical system.
Yeah.
And I think that's pushing so many of us to wellness.
Yes.
But wellness is kind of dangerous for us and a slippery slope. Can you talk about that?
Yes, it is very disturbing to me. And I get it. I understand you've been traumatized by a gynecologist or by when you delivered your baby or you almost died in childbirth, like half of us have, and you don't want to go back. And then there's somebody in the wellness space that's offering you softness and holistic view and all of this stuff. So we all want to be human, right? We all want to feel cared for. But if that person is not incorporating actual evidence-based treatments and therapies, evidence meaning like clinical studies that have been published, that where you,
I have friends who don't believe the studies.
Okay.
No, I'm being
No, I
serious.
understand.
These
And
are very educated people who like they're making that shit up.
Yeah, and all I can tell them is that I appreciate that concern, and I'm literally sitting in front of you as a Black gyn-onc scientific researcher. I don't make up my papers, right? And there
it's
are
the distrust. How do we
distrust.
mend
There's
that
a
distrust?
lot. There's a lot there. So what I would say is the problem that I see with the wellness thing, specifically when it comes to gynecology, is because the womb and the womb is so emotional, and it's so easy to play on those emotions and then have people suffering who don't need to be. So that's my concern when I'm like, listen, this woman has endometriosis. It is severe and there are treatments that work. Why are we having her suffer every month?
Yeah.
That does not make sense to me. Now, both and makes sense to me. Taking care of all of you totally makes sense to me.
You're like, I don't care what you do when you leave this
Are
office.
you kidding me?
But follow my instructions.
I mean, but
okay.
like we can put it together. Like I meditate, I visualize my
Yeah.
healing. Like I'm using every tool at my disposal. But the demonization of like this versus this is not helpful. And I would also say it's like another way racism is working.
Yeah, because culturally you need to integrate both paths.
You need to integrate both paths. And if I think of it as the legacy of racism, it's like medical racism exploits Black women, exploits Black women's bodies, creates distrust. Now and it's still ongoing. Then we have science that is done well, that is appropriate, that includes Black people, that have data that say, oh, this treatment works. That racism is still playing out because now this group is saying, well, I don't trust you. So now they're also not getting the benefit.
Yeah.
Here's what I want to say. Gynecology specifically was literally built on Black women's bodies. Literally. Why should we not benefit from what we've learned? And that's what I think I would probably say to your friends who might I don't believe the studies. It's like, listen, this research, if you believe that this research really came out of, experimenting on Black people and all this stuff, but like that's what built it out, then we should benefit from the scientific knowledge that created it. Why should only other people benefit? Yeah. I want us to benefit too.
I agree.
I agree.
Before we go, and on a final note, you talk about how to heal in the book, and you lay it all out. But the thing I honed in on was boundaries, like just the idea of you feel like boundary setting is one of the biggest tools
100%
at Black women and women in general's disposal.
Yes.
In terms of helping their womb health.
Yes, because so first of all, I told you to make a symptom journal. You need time. So you need time. You need like 5 minutes to be with yourself and notice what's going on with yourself. It is directly, when you set boundaries around your time and your energy and who you're dealing with, you're directly countering what we learned, which is bleed and be in pain and don't tell anybody and smile. You're directly saying, no, I am going to acknowledge that this is happening to me. Black women are strong. We are, right? Because of what we've had to go through. If we don't own that strength and modulate it the way we see fit, it becomes terrible. When we say, I know I'm strong, but I'm in charge of when I get to pick that up and put it down, which to me is what boundaries are. I get to choose. Then we come into full ownership of that history. Then I feel like I'm honoring the Black women who came before me. I'm honoring the fact that they gave everything to be able to say, I can modulate and live a joyful life. I think boundaries are critical for Black women. I don't know that we'll have a world where people stop asking Black women for literally everything. So for me, boundaries are non-negotiable.
Okay, that's so powerful. Dr. Kemi, thank you so much. Learned so much today. For the audience at home, where can they find you?
The audience at home can find me on Instagram at my full government name, KemiDoll, Kemi Doll on Instagram. You can also find me.
And you look like a Barbie doll. You do look like a Barbie doll.
They can also find all of the links, all of the things on my website, which is www.kemidoll.com. And they should definitely go check out my book.
Thank you. That's great.